Well, good afternoon, everybody, and welcome to TCT 2022. We are here together to discuss 4D ICE in evaluation of valvular heart disease and structural heart procedures. I'm very lucky today to have a panel of experts in the field. I have Dr. Azim Latib, who's a pioneer in many technologies of mitral, tricuspid, and valvular heart disease. Scott Chatterton, who is the Director of Clinical Trials in Oregon Health and Science University, and he's an expert in 3D, 4D imaging and structural imaging. I have Edwin Ho, who is does not need to be introduced, very well known for the work that he has done in echo imaging for structural procedures. Without further ado, I would like to introduce Dr. Chatterton. Scott, we look forward to hearing from you about integrating 4D ICE into mitral procedure. This event is sponsored by GE. Thank you. Go ahead, Scott.
Wonderful. Thank you, everybody, and please let me know in the back if you can't hear me. So it's my pleasure to speak this morning. My big thanks to GE for sponsoring this event. Here are my disclosures. So I wanted to set this up with two cases to run through. First, we'll talk about transcatheter mitral valve and then transcatheter TEER. But first of all, why use ICE for mitral procedures? Well, we all know that there's a potential for endotracheal injury, and we'd want to limit endotracheal intubation and utilize less anesthesia by the use of ICE, that we could go to conscious sedation. We're all very aware that that can help with a quicker recovery from the procedure. The other reasons are to limit potential pharyngeal and GI risk with interventional TEE. There's been a nice report published by Freitas and Faraz and others about EGD after structural procedures, showing up to 20% complex lesions in about 50 cases. You know, the strength of both 2D and 4D ICE are that they have very high spatial and temporal resolution. There's similar frame rates with 2D TEE. You can use 2D ICE to guide your transeptal puncture. And then with the integration of the new ICE systems, really with the new vision catheter, and then our use of the GE Vivid ultrasound system, you know, that probe by GE as well as the new vision ICE catheter have really equal frame rates both for color and for 4D imaging. So first of all, why use ICE in a valve-in-valve procedure? Well, really the valve-in-valve procedure is driven by a fluoroscopic implant. Again, you can use the ICE to guide your transeptal. You can image the mitral valve annulus both pre and post-procedure with ICE imaging. And really, if you need to, if there's any sort of complications, it can be converted to TEE, but you can assess RV and LV function with both ICE or transthoracic before and after the procedure. So our first case is an 83-year-old male that I've been taking care of for many years. He had acute papillary muscle rupture back in 2009, had a BioCore prosthesis for severe MR, did great for a long period of time, had some moderate MS, was followed, and then feedback. He presented in October of last year with pulmonary edema, dyspnea, and you can see on his transthoracic echocardiogram here, severe mitral regurgitation. So obviously the workup is with standard TEE to prove that he has severe MR. You can see the 2D imaging here with color as well as the 3D reconstruction. And keep those views in mind. So we worked him up for mitral valve-in-valve, gated CT to evaluate for any LVOT obstruction was completely clear, so we planned for a 26 millimeter S3 prosthesis. So here's our setup for the ICE imaging for the transeptal crossing. So we got left femoral vein access. We're utilizing our 4D new vision catheter. It's been advanced up into the right atrium, you can see here. Here's our BioCore prosthesis. You can see across the mitral annulus, this yellow line represents where our interatrial septum is. So as we're coming in with our ICE catheter imaging, now from the right atrium, we can see our transseptal needle, abutting the interatrial septum here at 0 degrees. So this will be inferior, this will be a little superior, or orthogonal view over here for distance to the mitral valve annulus. We're about 4 millimeters away. So we're able to accurately assess the interatrial septal cross effectively with our catheter. Now we're still imaging from the right atrium here as a wire has been advanced, and we have our sheath across the atrium, and we're even able to use 3D, 4D imaging from the right atrium to see the advancement of that catheter and its alignment across the mitral valve to help with wire placement. So then further after that, what we did is balloon septostomy. We put a catheter across the left atrium with an Oscor sheath to facilitate advancing the New Vision catheter into the left atrium now. And you can see the beautiful pictures we get with normal LV size, normal LV systolic function. We've defined the severe structural valve disease with the flail. Now again, as we hone up on that, you can see our 2D imaging here with and without color is very similar to what we got with for evaluation from the TEE that was pre-procedural. So we've defined our flail here, and now when we look at the 3D structures of it here compared to our prior TEE, you can see here there's our aorta up front, catheter across. We needed to Z-rotate that image. The beautiful thing about this system is you're able to use anatomic markers. So we put an anatomic marker on the aorta that was able to help us continue to identify it throughout the procedure if there are questions. So you can see the leaflet flail here laterally and anteriorly. So we have a good baseline assessment, and really the rest of the procedure is just fluoroscopically driven. So it's withdrawn, the procedure happens, the ICE catheter is placed back across the interatrial septum. There's a reassessment of the valve-in-valve procedure. You can still see our anterior image location, so we know when we're honing in on it with what is anterior, so there's no misidentification of landmarks. And with color Doppler, you can see that we're getting a great assessment and no paravalvular leak. So we thought this was a great example on how to, first steps of integrating this into your program. So what were our case learnings from this one with both 2D and 4D ICE? Well, valve-in-valve with ICE and transthoracic imaging is safe and effective. We limited general anesthesia for this patient. He was discharged the next day. It limited any risk of esophageal or GI injury. We did not really add any significant procedural time to it. It was still about a 60-minute procedure. And really just beginning with some straightforward cases helps your team build familiarity with both the 2D and the 4D ICE modifications with the flexi slice or multiplanar reconstruction, so you can expand its use into other fields for you. So we utilized those first steps, and we said, okay, well, our next step is that we want to integrate it into a mitral TEER procedure. So why use 4D ICE for a mitral TEER procedure? Well, some very smart and dedicated people in the field of imaging have done this before in the past. Carlos Sanchez, Gagan Singh, and Gilbert Tang actually published a case series of 4 patients who had contraindications to TEE, and they were either limited from strictures in their esophagus, a hiatal hernia, a Zenker's diverticulum, or severe C-spine disease that limited placing a TEE probe. Or you could see if anybody has oral pharyngeal cancer, you may want to stay away from TEE as well. So we took that, and you can expand then the indications for your own institution. We wanted to use it to improve leaflet visualization in challenging cases. We wanted to get used to it actually before we had those challenging cases and someone that was straightforward. We had a patient with significant mitral regurgitation, maybe a little restriction in posterior leaflet calcification, and we really wanted to build our program with, some straightforward cases before the expansion. So this is an 80-year-old male who has paroxysmal atrial fibrillation, hypertension, mitral valve disease. He presents with increased dyspnea on exertion. This is TEE imaging to kind of set the stage for what TEE and ICE look like. So you can see here there's a flail off the lateral aspect of A2. We've done flexi slice multiplanar reconstruction here to show the location of it. It's identified with color imaging, and you can can see the torn chordae there. So really our setup was pretty much the same. Femoral vein access for the transseptal from the right. We came in on the left side with a Oscor sheath to advance the New Vision catheter across the inner atrial septum. And now here are the images that we're getting with 27 frames per second, isolation of that flail on the lateral aspect of A2. So we went in with the TEER system here. We've utilized it to come in laterally across A2. We're aligned with the flail. You can see the flail leaflet here of the anterior leaflet kind of coming in behind us. We're using Flexi Slice to get right on it, so we have perfect views that are non-tangential to see it. When we first grabbed it, what we notice here with the paddles down here for leaflet insertion, there's still a little bit of a flail behind here. You can appreciate that here on the short axis view with multi-slice imaging as well. So what we did is we counterclockwise rotated that device with the ICE help. We have effectively now closed the TEER device, and then with color imaging and with 2D imaging, you can see that there's still a little prolapse out in the commissure. We do have some mild mitral regurgitation that's posterior and lateral to this. We didn't feel like that this was a significant jet medially, so we went ahead and we said, well, this is a good deployment of this device, and we can evaluate this commissural regurgitation afterwards. And we felt that actually needed another device, so we were able to follow up, go back in, and put a second device lateral out in the far commissure and A1 and P1 out here. And now we're utilizing ICE that you can see a device here out in the commissure, our first device placed just medial to that with near elimination of mitral regurgitation in this patient with our first application of this type of technique in TEER systems. So in summing up, what do we know about 4D ICE and transcatheter mitral procedures? Limiting endotracheal intubation and GE, I think, is a key in advancing your programs. We know that conscious sedation helps with patient recovery. We've talked about and we've seen the data on esophageal injuries that can happen. Your ability to treat patients when TEE is contraindicated. More and more of those patients for kind of last hopes are going to be showing up at your doorstep, and it's the heart team's decision on how are you going to offer them a potential procedure. I think this is a great way with program development as well. There are strengths of both 2D and 4D ICE. 2D ICE, you have great spatial resolution and temporal resolution. You're able to cross the interatrial septum. You're getting frame rates that are similar to TEE. And then with the system we've utilized, we're getting TEE-like color and 3D quality that mirrors what we get with the TEE from the New Vision ICE catheter. So, we'll do a discussion now. Thank you.
Scott, this is a fantastic presentation. I have to say, as an interventional cardiologist, what I do is I put stuff where you tell me to put them. And the two things about it though is, I don't know if I ever told you this, but I will right now. Sometimes when we do structural procedure, I look at the fluoroscopy image and I see where the TEE probe, and I got scared. Because it looks like it's flexing, it's going outside the body, and especially with a structural procedure, you wonder what is the risk of esophageal injury with those relatively extreme TEE manipulation that is needed to get the optimal image. And when we started doing ICE, I was very worried about manipulating the catheter in the left atrium. And the way we do it is we put the catheter and echo manages the console. But I remember in those two cases, what I did is I put the catheter in, and all the work was done on the machine. Like, there was very little manipulation on the catheter, if any, just maybe rotating the crystal 10 or 20 degrees in each directions, and we're able to get all of the image. Very little manipulation on the ICE catheter itself. What were your thought? Is that Is that how you think it is, Edwin? I'm also curious to see what your thoughts are.
Yeah, no, I agree with all of your comments. Actually, I'm glad Scott mentioned that study as well, where they did routine endoscopy, because it's something that I think is underappreciated on the structural imaging side. We think about just doing TE very routinely, but there is some risk involved. And I agree. The workflow piece is always sort of up for debate, I guess, in terms of how much manipulation needs to be done and by who. But for the most part, Nazim will probably weigh in as well. It's true. I think in a lot of situations, you can actually have a great catheter position, and then following that, really a lot of manipulation ends up happening digitally on the console itself.
Scott?
Yeah, I think what I've learned in these procedures is whether you're doing TEE or you're doing ICE, integrating your fluoroscopic view to assess the level of where whatever imaging catheter you use, be it TEE or ICE, is very, very helpful. So once you start integrating those into the procedure, you can both see from an ICE perspective, depending on your, the view that you're getting, maybe that's a little bit more anteflexion or low rotation here. And you're really thinking the same way as an interventional echocardiographer with TEE. It's just instead of the probe facing this way, the probe's facing this way now. So, and then when you build that strength or when you build that set, and you've utilized it, then whatever multiplanar reconstruction format you're using is just all a part of the process and comes natural. So these systems are a great setup for that. But it does take, it takes the appropriate height in the atrium, right atrial, I would say especially, and I think Edwin and Azim will talk to that, more in the tricuspid space.
I think, the workflow part is really important for people to understand, because for those who did 2D ICE and now, are evolving to use the 4D ICE, for us, the workflow's changed. With 2D ICE, there was a lot of manipulation, rotating, trying to find these images. And now, because we have 4D ICE and we have amazing MPRs and multiplanar reconstructions, our workflow changed. In the first few cases, I was trying to manipulate a lot. Even Edwin scrubbed in, he was manipulating, and I got to say he's better than me than manipulating, which I was surprised about, because I guess from TEE, you guys have this sort of idea of where the probe needs to be to give you that view that you're looking for, right? But our workflow's changed now. We now, Edwin tells me where to put the catheter, and I just listen. I put the catheter where he tells me, and then I let go of the catheter. And he's doing all the work digitally, and I think we like that workflow. It kind of allows us to work quicker, integrate this in a better way in what we're doing.
And Azim, as an interventionalist, I did not feel that it actually took my attention away from the device. I kind of put the ICE catheter and forget about it, like I'm doing a TEE. Has that been your experience as well?
Very much so. I mean, I'll find a good starting picture for Edwin, and then he just takes over, and he's doing all the manipulation. So I wanted to ask you guys, and talk a little bit about how we start using 4D ICE more in mitral procedures. So I think you showed two really great examples. The mitral valve-in-valve, I think, is a great place to start, to start doing this. My advice to colleagues is don't suddenly go do a edge-to-edge repair as your first case with a 4D ICE without TE, right? So I like using the valve-in-valve because there's so much fluoro, and it gets you familiar with how to do a transeptal, getting your catheter across into the left atrium. And then when you move on to using it in an edge-to-edge procedure, I would still suggest let your first couple of procedures do it in patients who you can do TE. Build the confidence in how to manipulate the catheter, how to get those images. And as you then get that confidence, you can then think about doing that patient with the varices or the patient, with a massive scoliosis who can't be intubated or whatever. And so do it in a stepwise way.
Yeah, I totally agree. And, as we integrated in the program, we used the most experienced, heart team coupled between interventionals and echocardiographer, two people that are used to working with each other. They're comfortable with the language, with the procedure, with the device. And I'll be honest, transitioning a lot of our procedures to ICE has resulted in decrease the duration of the procedure. We became faster. Even the room setup is faster, and and it really did not impact the workflow in a negative way at all. And on the imaging side, do you guys feel that way? I mean, oftentimes you have a sonographer with you in the room. How did the ICE change the workflow of what you do on?
Go ahead.
So I guess that's a bit institution dependent. At Montefiore, I don't have a sonographer with me, so I'm doing all the imaging with the TE, both the probe handling and the console handling. So in some ways with ICE, it's actually really nice because then I don't have to worry about the probe part, and I can really then just focus on the software side, which is quite nice. So that part on the workflow, I think, is actually a significant advantage.
So the workflow in our system is we've developed interventional sonographers as well, because they help do our TAVR program and lead the TAVR program from a transthoracic standpoint. They're the sonographers in all of our advanced transcatheter mitral and tricuspid valve procedures. So I integrate them into the procedure as well. I think it's important in kind of program building, if you have enough sonographers, to identify those people that want to help lead the program. They really know like the ins and outs of every system and that knobology to a higher degree than what I could get. Now, Edwin is obviously a master at this, and so he's handling it himself. But I like that backup. I like the teamwork. Plus, it just gives me another person on my side. If I don't agree with Faraz, they typically agree with me.
And you can gang up against it.
You gotta have a buddy in the back with you,
especially with Faraz.
Yeah, exactly.
You need it. The introduction of ICE, where initially is like, okay, what is going to happen between the relationship between the interventionalist and the echocardiographer, and how is going to be perceived. But reality, I think it got us even closer. I mean, now Scott understand interventional more, and I understand echo a little bit more, and got us a little closer. It might be a scary thought, Scott, but
I know.
It's a fact.
Yeah. I think these are all great first steps, but there are things that, we're still going to want and need from imaging companies. When you guys are working at your end of the table, you've set your ICE catheter, then, the stability of that over time can change. You're utilizing towels and other structures to hold your catheter, and that just doesn't need to be the case.
Yeah.
There are other support structures out there to help with the stability of the ICE catheter that need to be integrated in these procedures, just like with the support of our transcatheter mitral or tricuspid devices.
Right, so kind of having a dedicated stand or something. So
something, yeah,
yep.
I think would be helpful, because then you really can park it and make those finer manipulations, even with a stand, as far as a little bit advancing. I think if you're not necessarily used to it from an imaging standpoint, that could really add value to the interventionalists on your end, and then I can stand as far away from the fluoroscopy as possible, which would be great.
And so let me ask you both a practical question. We've started now using it also for mitrals. We started really for tricuspid, and Edwin will share some of their experience in the next part of this session. We then started using it more for mitral, and one of the challenges I have at times with mitral and using 4D ICE is the transeptal puncture. I have to admit, it may be my limitation, so I want to get some hints and tips for the audience, because I'm so used to TEE and the imaging you guys show me on TEE that I can very quickly see my bicable, I can then quickly see posterior, anterior, and then I can get the height. I've struggled a little bit with getting all three of those views with ICE, particularly the anterior, posterior. I can see the septum and get a sense of inferior and superior, and I can also get a sense of height with a 4-chamber. Any tips for me?
So I share your concern, Azim. I mean, with the beautiful thing about doing it with this catheter is, little dorsiflex in the right atrium, and you're able to rotate the crystals. If you're using any other catheter, then you have, to rotate the catheter, and you get into the whip effect, where you change your location, versus in this case, we had a little dorsiflex in the right atrium, and we rotated the crystal, and we got to the point where we can see where we want to be in the bicaval view, and then, after, we had the tenting, we rotate again, and sure enough, we knew how high we were. I was, it's a little, it takes a little bit of a learning curve, but I think that once you get used to, the crystal rotation as opposed to the catheter rotation, you will like it because it's not going to change the location of the tip of your catheter.
So I think that's really important for the audience to know as well, right? Because we're living in a world where there's now potentially 3 4D ICE catheters, okay? And they're not all built equal, right? As far just from a catheter and what the catheter can do. And I think what is unique and what I've liked about the new Vision is this ability to actually rotate the tip of the catheter independently, right. And I think that's unique to this catheter.
And also there's two shape of the curve. So if you have a small atrium, you can actually turn the catheter 180 degree and rotate it, and it will be a tighter curve. Right. So you'll be able to have a sharper turn. So even in smaller atrium, you can still have a good visualization of the intraatrial septum.
Those are all great tips. Absolutely.
Well, Azim, without further ado, I mean, you want to introduce the tricuspid part of this session?
Yeah, absolutely. I think let's move on to tricuspid. We'll hopefully have some even more time at the end to talk about workflows and how we use this catheter. So it's a real pleasure to introduce my partner, Edwin Ho, who's going to be talking to us about integrating 4D ICE into tricuspid procedures and really, what we've done at Monty to make this catheter a part of our daily practice.
Okay, great. Thanks for that introduction and great discussion so far. And thanks again for GE for sponsoring this session. So I'm going to spend the next 10 to 15 minutes talking about how we've integrated 4D ICE into tricuspid valve procedures. We'll talk a little bit about the specific challenges with TEE and then some of the advantages that now 4D ICE can really offer. We've already seen a little bit about the advanced 4D image handling, but I think that that's really a big advantage, especially with the new Vision system. And then the current setup for us, and then maybe some sort of future directions and thoughts in that end. So tricuspid TEE imaging, of course, can be super easy sometimes, and then sometimes it's just really, really horrible. And there's a number of factors that drive the difficulty, but we all know that good imaging is really critical for both evaluation and then, of course, for interventions. And why is that, of course? Because the more we look at the tricuspid, the more we realize how variable and complex the anatomy is. So we think about it as a 3-leaflet valve, but we've quickly learned that in many situations it's really not. 4, 5 leaflets in this situation. This is a TEE transgastric view, but just as a good example of this morphology variability that we tend to see. And then as a result, when we see especially functional TR, we often also see that the jet shape can be very, very complex. So in this case, it looks more like a star than like a true circle or an oval. We also know that the complexity is there as well, in particular when we're thinking about the subvalvular apparatus. So there can be a variable number of papillary muscles, the location can also vary, and even the density of the chordae can be quite variable and can really influence in terms of what sort of device may be most appropriate and may be most successful. So why do we have so much difficulty with TEE imaging? So there are a number of factors, but one of the really, really big ones, of course, is shadowing and interference, especially from left-sided structures. Because of the contact position of the TEE probe, especially when there's prosthetic material. So in this situation, here's 3 angles done with the TEE, where there's a mechanical mitral valve, and you can see it cast this really huge shadow that covers really a vast majority of the tricuspid valve. So it makes visualization very, very difficult. And then in addition to that, a lot of times the position of the esophagus and where the probe likes to settle in its neutral position will make the heart look almost a little bit horizontal. A lot of times that's a combination of potentially a shift in the position of the heart, but also the relative position of the esophagus to those cardiac chambers. So here we see that, again, on a TEE image, we see that the leaflets are actually very well visualized, but that's with the fact that there's nothing actually sitting in the right atrium and no device in place. On the right side of the screen, I've drawn a red line, which would be, where a catheter may be sitting with a device for the leaflets, for example. And usually then we'll get a huge shadow that's really going to cover that lateral annulus and lateral side. So even though it looks great on resting images, during an intervention can be very, very challenging. So then what are the advantages of ICE? So the probe position, of course, is hugely different. So instead of sitting in the esophagus, typically behind the left atrium, in the mid-esophageal view in particular, of course, now the ICE catheter can be placed directly in the right atrium. And that gives it a direct line of sight to the tricuspid valve. And what that means is that the proximity of the probe is now closer to the valve, so we're dealing with typically more near-field imaging rather than far-field, especially when the atria are very dilated. And even though shadowing can still happen with the presence of devices, the shadowing is significantly reduced. And then, of course, with the esophageal position and the esophagus in general, we talked also about disease in the esophagus and contraindications for TE. Of course, now we're free of all those restrictions. So then what about 2D versus 4D? So again, we've already alluded to this a little bit. With the conventional 2D ICE catheter, of course, you can only generate a single imaging plane. So to move that plane around, we're really talking about catheter manipulation. So a lot of rotation and then potentially flexion, either in the left-right direction or anterior-posterior. 4D ICE has the advantage where you still have the catheter manipulation, but now also on the crystal you can manipulate that imaging plane, and we've seen already great examples of that on the mitral side, and this is particularly also relevant for the tricuspid. So we've already seen a little bit about this New Vision catheter and discussed it briefly. So this is the system that we're showing examples from, where we have also mentioned that there's multiple degrees of flexibility with the catheter. So there's ability to actually do flexion, so 30 degrees in one direction, 120 in the other. And then, as mentioned, there's that 360-degree tip rotation, which really allows a lot of fine manipulation without having to actually physically move that catheter. And then, of course, on the software side, it's going to be driven really on the G side, typically with an E95, but also the S70 is capable of handling all the images. That moves us towards 4D image handling, which again for tricuspid has been very, very useful for us as a workflow point of view. And why is it important? Of course, because as we discussed, if we can minimize the physical probe movement, that's of course ideal. And it really helps a lot with team communication. And so that again allows us to make our procedures faster and potentially also safer. But at the end of the day, the tools are only as good as they are if they're high quality and, of course, user-friendly so that we can actually be doing this in real time. So a couple of quick examples in terms of the tricuspid imaging that we've done at our center. So we've heard a little bit about FlexiSlice, so that's live MPR, that really gives us the flexibility of taking this 4D volume set and actually creating these 2D slices out of it. And the really nice thing about it, especially in the tricuspid, is that the flexibility of those slices is actually more or less unlimited. So for example, here we see there's two short axis views, one in 3D, one in 2D, and we're able to generate off of that basically the plane that's parallel to the septal leaflet, and then also the orthogonal views which show our leaflet pairs, which in this case is anterior and septal. So, if we're thinking about devices that will, actually interact with those leaflet pairs, it's really nice to be able to see them in those pairs exactly. And then the other nice thing that we see here is that the volume rate and even the spatial resolution is actually really, really good. So leaflet visualization is really excellent, and in a lot of situations is clearer than what we see on the TE because of those advantages that were mentioned before. Every once in a while, though, 4D is still not quite as sharp, of course, as if we're using 2D images. So biplane, is something that we still will need to go back to every once in a while. And one of the really nice features that's available, again, with this particular catheter is the biplane prepare. So this is where we're able to define our biplane off of the 3D, which is nice because then we don't have to be looking for those angles. And again, for tricuspid, can be quite variable depending on that leaflet morphology. So off the 3D, we can actually generate exactly which planes we want to be using and then have the advantage of getting that spatial and temporal resolution that we all know and love from biplane imaging itself. We've seen a little bit about the 4D markers, which I also really like using myself, because in many situations, we start talking about, okay, I've put the septal leaflet at 9 o'clock on a clock face. When we have markers available, we can actually just put a dot there. And then it shows up on all of the reconstructed planes as well. And then communication becomes very, very straightforward. So we all know what we're talking about. We're all on the same page. And again, just from a procedural efficiency and safety point of view, can be hugely helpful. The other sort of nice thing on this example here is this is a special MPR setup that was added more recently, where we actually are able to generate more than just the typical 3 planes that we see. So here you see there are 2 short axis views on the bottom left corner, and they can be placed at different levels on the valve, which is again really great in tricuspid, because if those leaflets are more tethered than what we're seeing here, we can place one level actually at the level of the leaflets, and then if we need to see the annulus, depending on the type of device or intervention, we can actually see that simultaneously. So again, it really gives us just yet another degree of flexibility. And then because we can define those planes at a really exact distance, it can also help sometimes if we're trying to sort out, the actual height of a device, for example, relative to the leaflets or relative to the annulus. And then, another quick point about 4D markers. So sometimes, when we're looking as a team at MPR views, it can be a little confusing. So, which side is which. So on top of those ball markers that I showed, just another nice feature is, if we start moving around the plane with the ball, there's actually a laser point that will follow in the other views. So here on the right side of the screen where I've highlighted in that red box, if I'm moving out to the lateral side, you see on the short axis that laser point shows exactly where my mouse is actually moving. So even without placing a permanent marker onto the leaflets, again, just from a communication point of view, especially for tricuspid and the complexity, has been very, very useful. And then image rendering. So image rendering can be very, very useful again in terms of evaluating tricuspid for different details around the leaflets, or in this example here, this is a bioprosthetic tricuspid valve that we were trying to look at and treat. And so on the left side with conventional rendering, we saw that there is a little bit of a shadow there on one side of the sewing ring. And the question, of course, was, well, is that actually a defect or not? And of course, we can evaluate with 3D color to see if there's a jet coming through there, but a nice ability to actually manipulate the light source for 3D rendering can also be very helpful. So in this case, we put a little ball of light and we actually can use the touch screen to manipulate that. So we sort of move that down towards that shadowy area. And then what we were able to see is when we put the light source there, actually it looks okay. So the tissue looks intact. And it was just another nice sort of confirmation for us that, everything does look okay. So where are we at in terms of workflow and 4D ICE in tricuspid interventions? So in some of those examples that I showed, really we can see that most of those mid-esophageal and lower esophageal TE views can be easily replicated with the 4D ICE catheter, such as this one from New Vision. And it's really helpful when leaflet visualization is difficult, especially with the TE on the tricuspid. So it can be a good adjunctive imaging modality for tricuspid. The other workflow point of view that we found very helpful that's quite nice, we talked a lot about esophageal pathology, risks, and injury in the last discussion. And for tricuspid, a lot of times we need to go back and forth between the transgastric view to actually see all of the leaflets. So when you can do this, 3D manipulation where you can very clearly see, orientation to leaflets, orientation to the annulus, it reduces the amount of times that we potentially need to cross that G junction and hopefully reduces the risk, again, of trauma in that situation. And then the other potential workflow that's worked for us is actually to leave the TE probe in the transgastric view. And that way, we always have that available for that really sharp on-fast view of the leaflets. And then we kind of use the ICE for our mid-esophageal-like working views. And then again, it just, from an efficiency, safety point of view, is actually really, really nice. And then so for us, just like many other centers, of course, we're slowly building experience with using 4D ICE in our tricuspid workflow. And then, at all these meetings and everyone I talk to, of course, there's clear interest for all the advantages that we've already discussed. And then what about the future? So, I always have my own personal sort of little wish list and things that I think are coming actually as well. So as an echocardiographer, I'm always going to want as much volume rate and as much spatial resolution as I can get. So, that's always improving as technology is improving. So that's always a great advantage to see in the future. We already saw some great example from Scott, actually, that the color Doppler has really gotten a lot better recently, so it is actually quite TE-like now. And so very, very usable, but especially in the 3D sense, it would be really nice to have those very, very high volume rates so we can really evaluate color jets. And then other software enhancements. So, we saw the special view sets that we had. So for example, the dual short axis view. And then as new technologies come around, there may be other imaging needs where special presets and other setups would be very, very helpful. And then lastly, Fusion. I think everyone's always trying to sort out how Fusion fits in well with their workflow. But being able to fuse live images is always potentially advantageous. So being able to fuse ICE imaging on top of fluoro in particular, I think can be helpful. And then if we can integrate also, if there's been CT screening that's happened, all of those things can have added value when they're combined together. So in summary, what do we go over? So we looked at how 4D-ICE can overcome some of those imaging limitations we see with TE, specifically for tricuspid. So right now it's a great adjunctive imaging modality. We've also seen some of the 4D handling that can happen that really I think is the big advantage of 4D-ICE over, of course, 2D-ICE. And then some of those examples that we showed here, FlexiSlice, biplane prepare, the 4D markers, and FlexiLight. And then as a result, I think it's quite clear that especially for tricuspid, there's really a significant future for 4D-ICE, and I think it'll be very helpful. Thanks.
That was really a phenomenal presentation, Edwin, as usual. It's given us, I think, a lot to discuss. But I think one of the things before we actually talk about practical parts of the workflow, and again, it brings me back to the fact that we now have 3 different catheters from 3 different companies. One of the things you really highlighted, which I think people need to realize, is how important not just the catheter is, but also the system you attach it to, and how the systems differ. There's a lot of image processing and functionality that the GE system has that I don't see on other systems, or other systems still need to catch up on. So, I don't know, Scott, maybe, if you can make a comment. You've obviously used more than one system too. How much do you use all this post-processing? Are you using the markers? Let me give us some insights to that.
Yeah, I think it's very helpful to, marry your TE probe and your ICE imaging probe on the same system to have that comfort level, because then you can quickly manipulate back and forth between the two. When we first started, we were using System A for TE and System B for ICE, and that will add time to your procedure length going back and forth when you're developing that. So if you have the ability to build the same platform in your institution, it just bodes well from a program building standpoint. The additional things that Edwin showed to, I think, layer on from what we've seen in the FlexiSlice for a transcatheter tricuspid valve procedure, the ability to have one slice at the annulus as well as another slice at the leaflets. I got to figure out how to do that, because that's great. So I'm still here learning about this field as well. So, but when you think about those procedures, identifying each of those targets is very important from I think more a transcatheter replacement strategy, but it could be helpful in TEER strategies, tricuspid strategies as well. So, the more familiarity you build with your system and the input that you have from the industry sponsors on what further capabilities you can build onto it once you get to a comfort level, that partnership is always key in any sort of system and patient care, truthfully. Yeah,
so the one thing we've done, I think we're using now an ICE catheter in every tricuspid edge-to-edge repair procedure we do at Monty, and the reason being it's part of it's learning and trying to get better, but also because it's added so much value. That since we've started doing that, our procedures are shorter. We feel more secure about the fact that we've grasped sufficient leaflet and we can really see how much leaflet we have in. And I think our outcomes are also slowly getting better, because when you have a quicker procedure, and you're not sitting there for 3-4 hours trying to figure out, do you have enough leaflet in? I think you do a better job too. So we've really integrated it at Monty as, kind of standard of care. Firaz, what are you doing at OHSU? I mean, how often are you using it in tricuspid procedures?
We use it routinely as well. I mean, it shortened the procedure time in our experience, and it adds that level of confidence. When you're not sure, when TEE is challenging, it adds that level of confidence, and it actually does not take time. It does, it's a contralateral access, which is venous, and it's not that large, and we never had any vascular complication from introducing it. So we also use it very routinely, and I think it is important, especially on tricuspid, Azim, to realize that there is no commercially available product. So imaging is actually progressing as the devices are progressing, and we're doing that hand in hand. So hopefully, when we have a commercial product, we'll be in a place where we figure out the best way to image it, as well as the best way to use the technology. So it's very exciting, and I think ICE will be in the future of tricuspid interventions for sure.
Yeah, absolutely. I think it's certainly been a game changer for us in tricuspid. And initially it was about getting around those challenging imaging cases that Edwin showed in the beginning. The patient with a mechanical mitral valve replacement or with a ring, and the patient with a very horizontal aorta. And now it's just become, we want to use it in every procedure, because being able to really see the grasping, seeing the orientation, and the trajectory of your edge-to-edge repair device has really allowed us to do it better. What about valve replacement for us and Scott? You guys are one of the leaders internationally in tricuspid valve replacement. Are you using it in that indication too?
We are.
Yeah.
And we think that the reason why we use it in edge to edge is similar to the reason why I use it in replacement, and especially that right-sided disease is often a sequela of left-sided disease. So a lot of those patients have a mitral valve or a mitral ring or an aortic valve. So the challenge of imaging is true as well. Now, do we need to use it for all devices and at all times? It's premature to answer that question, but I think that it will have role in replacement as well.
Yeah. So maybe there's a lot of our colleagues out there who are going to be watching this who are still new to ICE catheters and 4D ICE catheters. How do we help them get started with this? Is it something that the echocardiographer should be pushing? Is it something the interventionist? And do we need to develop standardized workflows so that those who are new to it can say, okay, if this is the procedure, this is where my catheter should be on fluoro, this is kind of what my basic picture should be. How do we help grow this field?
So I'll jump in with that one. So when we were first thinking about this, it was like, should echocardiographers be scared of ICE imaging? And the answer is no. You should not be scared of ICE imaging. It's a technique that you need to adapt to, learn, and that you'll actually be predominantly in the driver's seat for it. So there has to be echocardiography buy-in, because your role as a structural person is not limited to just your ability to manipulate a TEE probe. You're an integral part of the procedure and a driver of the procedure in many ways in the heart team. And so having a technique that may be safer, more effective, and can lead to better procedural outcomes in the future, I think is key. So without the first step of the imaging community being integrated into it, I don't think you can really get a foothold on it. Otherwise, it's just an IC pushing it onto a lab. So there has to be investment from ACE, and really the imaging community, because you're not going to be replaced, I don't think. You'll maybe be even better displaced from the head of the bed and the fluoroscopic radiation that we actually get. And to be on a console and be part of the procedure, or to be part of the procedural table and actually driving the catheter and then manipulating as well with your advanced sonographer is another aspect. So I'll let Edwin jump in from there.
Edwin?
Yeah, no, I agree with that. Definitely the buy-in on the imaging side is important, and I agree with you as well that, I think people are a little hesitant sometimes when they see this technology and, what's going to happen in the field of interventional imaging. But I think especially with the 4D manipulation, I think there is a huge role from the echo side of things. I think the positioning that you kind of mentioned is also important to note. And, even for us, we had the same sort of issues with multiple, consoles and the length of the cable being a little bit, limiting in terms of where we can place that. So these are all things that I think going forward in the future, hopefully will continue to get better and we'll be able to optimize the actual setup of the room and the workflow.
So, back to sort of the second part of my question. How do we train people? How do we get people to use these catheters and gain from some of the experience we have? Is it having simulators created by industry? Is it like we're doing now, showing cases? Is there a way we can make it easier for new centers who want to start using isostructural procedures to move up the learning curve quickly?
So I tell you what we did, and we did some bench testing where we initially went in with ice catheter, and we tried to figure out what is the best position for ice catheter. Scott was the first author on the paper we published in Structural Heart that many sites participated in the tricuspid TEER procedure, and it's really about getting over the fear hump of I'm going to use it, but it's going to be problematic. It's going to distract my attention from the device. It is going to be confusing. It's going to send mixed messages. I think most people will find after the first case that all of those fears are not real, that it will add value, it will increase confidence, it will not add risk, it will not distract attention from the procedure itself. And even the cost that is associated with the ice catheter, and I'm hoping that we figure out an ultimate solution for the cost, but in terms of reimbursement. But even at this early stage, cutting the procedure time and getting that confidence, especially when we are all learning the new technology, is priceless.
So I was just going to add, one, publications from people who have been using it are exceedingly helpful to put it out there what your comfort level is in it. So that's step one. Two, we have to be able to demonstrate added value. So added value can be procedural time is an added value for potentially less GA. So we have to think about these things that are added value for us. And we have to, bargain with health systems about, what are the devices that we would like to use as providers, and how to get a foothold of those in your respective institutions. And it's going to take the publication community to really get behind that. So,
Edwin, for a track, I'm hoping we finish enrollment in the Triluminate study. That I'm hoping that study is positive. So maybe next year we'll have the first commercially available tricuspid procedure in the United States. Can you imagine in the future doing an edge-to-edge procedure ice only? Because that's the big thing people are talking about, right? Can this replace TEE with the potential advantages of, like Scott mentioned, maybe less GA, less cost, patients, being mobilized quicker, going home sooner, without the trauma to the esophagus? Do you see that happening?
Yeah, I think so, and especially because, as we all know, a lot of tricuspid patients are quite high risk, and probably that risk of bleeding and esophageal injury may even be a little bit higher than potentially mitral. And so I think that there's really good potential. I think the 3D capabilities will be really key just because of that leaflet morphology piece that I had mentioned. Because once we lose a transgastric view, we want to be really sure that we can still see what we need to see. And I think that's where that 3D really comes in.
I tell you, Azim, many of us on this panel are old enough to remember if the year before TAVR was approved, you asked that question, do we think we can do TAVR with cautious sedation? People will say, what is happening? There's no way. And now as you said, we're probably a year before the first device in tricuspid is approved, and we started talking about, can we do this procedure with cautious sedation? And I think ICE is the main reason why we might be thinking that way.
Yeah. I think so too. I guess the one hesitation I have, and it's because I get to work with great people like Edwin and Scott, and I have so much respect for the work you do. We have to figure out the reimbursement part, though, for you guys, right? Because that's the part that kind of concerns me a little bit. You are as important a partner in that procedure as we, the interventionists, are. Yet, I think from a reimbursement perspective in this country, we don't give you the correct recognition for the work you do, and we need to fix that too. I think that's, for me, a really important step in order to be able to move these procedures to conscious sedation, is how do I make sure that Scott and Edwin are reimbursed for their time, because their time in the lab is super important. I mean, all that manipulation they do on the catheter, on the system, is more important than what we do on the catheter. Scott?
Well, I would just say thanks. So, number one, thanks. Two, there are a lot of great imagers out there, right? So part of the imaging community needs to be invested in this space. So Edwin and I and others that are in our field here at this conference are in a really good position. I think there are a lot of people in training that are looking for this type of career and lifestyle, and team of taking care of patients in that heart team imaging standpoint. So I think that's going to grow, and we'll hopefully address kind of those bigger global issues as a community together. But the more imaging input you can get into an interventional field, as well as I would say the opposite of getting interventionalists integrated into the Society of Echo. There is so much overlap. This should not be a interventional conference. This should be a heart team conference of taking care of patients with structural valve disease. And it takes an interventional cardiologist, it takes an echocardiographer, it takes a CT surgeon, and we need that type of teamwork to really advance patient care and research. So I'd follow up by saying I think the next steps after whatever commercial device is approved, there are ways to set forth figuring out what the added value is outside of a clinical trial. Right. In a clinical trial, you're not going to necessarily be able to do that, but outside the aspects of a clinical trial, the added value of TEE time versus ICE time those questions can be answered in the market.
Yeah, I mean, I agree. I don't think ICE is a way to get the echocardiographer away. I think it's a reason to get the structural echocardiographer closer. And I agree with you. We need to figure out the reimbursement. Mm-hmm. I buy Scott a drink every time there's an occasion, but that is not enough. And we need to be able to solve this as a community, mm-hmm. and moving from a proceduralist to a procedural team.
I appreciate the free coffee you got me this morning.
Absolutely. Yeah. So, I mean, we've got a couple of minutes left before we just summarize, mm-hmm. and close the session. Looking forward, into this field of using ICE to guide structural procedures. I think we talked about mitral, we talked about tricuspid, mm-hmm. we talked about the fact that this could potentially be done only with ICE certain procedures. Any other indications you see where in structural heart this catheter is going to be impactful?
I mean, there are transcatheter aortic procedures that are currently utilizing TE for commissure alignment.
Yeah.
I think you could likely do that with ICE imaging as well. Although obviously people are getting great at just the fluoroscopic keys for that. There's two other valves that we haven't talked about. We have, a burgeoning, congenital heart disease explosion that is going to come from the pulmonic valve, and we have valves out there that can be utilized. So making those procedurals quicker and more effective, and potentially without TE and ICE and fluoroscopic guided, I think are out there as well. So that's a part of the structural heart team as well. So there's no need with it. We need to limit them to the AV valves.
And I think Edwin gave us a few interesting things on his wish list about fusion imaging, about getting sort of better frame rates. I think we need to remember that this is kind of just the beginning, and we need to continue to evolve both the catheters as well as the system so we can improve the imaging. So I think we've come to the end of the session. I hope that between me, Faraz, Scott, and Edwin, we highlighted, number one, the importance of teams working together. And these procedures, the success of them is not just technology, but it's technology with the right teams, and how important structural interventionists and imaging specialists work together and how they can get great outcomes. I think we've taken you through how we can use the catheter to perform mitral procedures, both mitral valve in valve and edge to edge. And I think we're going to continue to see growth in that area. And I think most of the panel agrees that tricuspid, with these catheters for tricuspid, it's really a game changer and is allowing us to get better outcomes and shorten our procedural times. So we look to in the near future showing you even more cases and how we're going to apply this technology in more patients. Thank you so much for joining us today.
Thank you all.